My name is Josiane Malo and I am a NICU pharmacist. Today I'm delighted to present this poster on adrenal function following SToP-BPD protocol, and I'll talk about our experience with my colleagues at Saint-Justine Hospital, a mother-child center in Montreal, Canada. In our unit, hydrocortisone is the primary corticosteroid prescribed due to concerns related to dexamethasone neurotoxicity. Introduced in June 2022 in our Level 3 NICU, the SToP-BPD protocol represents 72.5 mg per kilo of hydrocortisone over 22 days, starting with 7 days at 5 mg per kilo per day in 4 doses, and ending with 5 days at 1.25 mg per kilo once daily. Given the risk of adrenal suppression and lack of published data in this setting, the adrenal response of all initial infants treated has been tested as part of their clinical monitoring. The absence of a validated criteria for diagnosing adrenal insufficiency in neonates led us to establish local thresholds. The most reliable measure of adrenal response is the peak stimulated cortisol level. Our threshold was set at 350 nanomole per liter 30 minutes after 1 microgram IV cosentropin because a weaker response under these conditions was previously associated with worse outcomes. This is about 13 microgram per deciliter, although variation exists between different analytical methods. We wanted to describe cosentropin test results and identify predictive factors for test outcomes. So we undertook a retrospective case series of consecutive babies treated with the SToP-BPD protocol without any other corticosteroid. We collected data from 18 newborns, with 8 showing a satisfactory response in the cosentropin test and 10 exhibiting unsatisfactory results based on our local criteria. The average gestational age was 26 weeks, and the median birth weight was 765 grams, and newborns with an unsatisfactory response had a 200-gram lower birth weight. There were 3 cases of severe IUGR, all of which had an unsatisfactory adrenal response. These data cannot confirm IUGR as a risk factor, but its association with a reduced adrenal response has already been shown in several studies. Other characteristics were well balanced between the groups, and cosentropin tests were done around 31 weeks postmenstrual age. With our small sample size, the only statistically significant result is the serum cortisol level after cosentropin administration. On this figure are 18 bars, each representing one of the patients. They are presented in ascending order of gestational age, with the most immature at the bottom of the graph. On the x-axis, time is expressed in days. The white bars represent no hydrocortisone, the dark blue ones supraphysiological hydrocortisone, and the light blue ones physiological hydrocortisone. Unsatisfactory test results are shown by pink question marks and satisfactory results by green happy emojis. As in previous studies, there was no correlation between stimulated cortisol levels and gestational age, since test failures were well distributed across gestational ages. Among 10 patients with unsatisfactory responses, 1 skipped further tests, and 3 were still on physiological hydrocortisone during data collection. Of the remaining 6 patients, 2 had a satisfactory response on the second test, 1 did so on the third test, and 3 had unsatisfactory responses up to 3 times. Here are the pre and post cosentropin values for all patients. Failures are shown in pink, successes in green, and the dashed line indicates our threshold. To conclude, over half of newborns had an unsatisfactory adrenal response after a single SToP-BPD protocol. We could not define any predictive factor for test failure, except perhaps for IUGR. Our data are limited by a small sample size and lack of data adjustment, and we believe that more data are needed to better target babies with adrenal insufficiency.